All right, thank you everybody and welcome. And so this is our second call to action dialogue for better planning, better care, better work through better health workforce data. So some of you have seen these slides before. We've updated them. And just to kind of give you a sense of, overview in terms of the burning platforms, health workers account for more than 10% of employed Canadians and over 2/3 of healthcare spending, which when you calculate it constitutes 8% of GDP. And a large number of these are data from 2019, 175 billion. We also know that health workers experience endemic levels of burnout and work overload. This predates the pandemic, but it has been exacerbated by the pandemic. These we want to sort of walk you through the paths are a result of poor planning, which in turn are a result of poor health workforce data. And the pandemic, as you know, has exacerbated these trends, causing critical and systemic risks, not only in the short term in terms of surge supply, but also with long-term implications for attrition. And given that we are going to have such long wait lists for many procedures, this is really quite critical. So some of you have seen this visual before. So our argument is to focus our solutions upstream. That burnout is caused by work overload, poor planning, and a lack of data. And so if we don't focus upstream, our downstream implications are going to be rising attrition. And so also to kind of give you that sense that health systems have two sides of a coin. We have on one side population health needs, and we need data for that. And we need to understand that there's a workforce that has capacity to meet those population health needs. And as the WHO has argued, health workers are the foundation of health systems. And so planning requires data on both sides. We need to have sort of population health profiles as well as workforce profiles to understand what are the service requirements and service capacity, to assess whether there's alignment or misalignment, how we might go about allocation and where there are the gaps and how we would adjust policy levers through different scenarios along that path. And so this is a visual from work that Sarah, Carolyn, and I have done with the Toronto region that will be coming out in Human Resources for Health shortly. So what we have now is an incomplete and misaligned state of health workforce data in Canada. And I focus here mainly on the data that we have that's pan-Canadian at the Canadian Institute of Health Information. And I chose silos quite purposefully because we have good data on physicians, which doesn't necessarily articulate with the data on nurses, which doesn't articulate with the data on pharmacy, physiotherapy, and occupational therapy. The data that we have about other regulated professions is really egregious, that we have gender, age, and province, and that's it. And there's a whole host of unregulated roles that we don't have any data on. Perhaps most salient to everybody in light of the crisis in long-term care are personal support workers or healthcare assistants. But there's also a whole host of mental health and substance use workers that we have no data on. So these are undiscovered countries in essence. It's also important to note that much of the data that's gathered by the Canadian Institute of Health Information, which is coming from registries, is not aligned necessarily with national occupational codes. So there's some misalignment there. So data that we get at StatsCan doesn't quite mesh with the data from regulatory authorities and other sources. It's important to note that we have critical knowledge gaps, and from a broader gender-based plus perspective or an intersectional gender perspective, we have beyond sort of a binary male-female, we don't have any nuances there. We also don't have any data on racialization or Indigenous identity, although there has been discussion that they were going to be collecting this in British Columbia as part of the response to the calls for action from the Truth and Reconciliation Commission. We also have very little data on disability and recognizing the complexity of that, but these are requirements from employment equity legislation that has been on the books since 1996. We also have legislation around our languages, including Indigenous languages, and so there's variable data on language of service. And so representation and self-determination matter. So these initiatives would, of course, need to be led by these groups, but not addressing it needs to be addressed. It's important to note that health workforce data includes not just quantitative data, not just numbers of who's where, etc., but also qualitative data that addresses context and emerging trends, what we would call health workforce intelligence. And you want to have both of these types of data available in toolboxes so that people could use that. And so ideally, trying to kind of figure out what would be an ideal health workforce information system or intelligence system. It would collect standardized census or registry-based data so that you know exactly who is practicing and not practicing and how much. It would be inclusive of diversity data along career pathways and collected for planning purposes, not sort of repurposed from something else. It would align across a range of stakeholders. It'd be accessible and digestible in interactive platforms that enable interpretation and to support and align decision-making along these paths. So this is what we hope to achieve. We're not there, and how are we going to get there? So a little bit about sort of a health workforce career approach. We would want to have data across the pathway from recruitment to training, registration, promotion, retention, and retirement to get at those sort of quality of work issues. And so we would need to have health workforce data that maps it along the way, recognizing that there's a variety of different stakeholders along this path. And right now, the data that are being collected by these different career course points are often misaligned. So they're difficult to line up. So that results in a lot of data collection burden as well as misalignment. So it's important to note that all of these stakeholders are part of a complex adaptive system, which is what the health workforce is. So it's complex in that it denotes a diversity of stakeholders with sometimes conflicting goals and behavior. It's adaptive in that we are able to alter, change, the ability to learn from experience, but also to learn from data. And it's a system in the sense that it's a set of interdependent and connected elements. It may not be totally aligned or coordinated, but it's definitely a system of interdependence. So we're going to have a couple of examples that we look to for a bit of inspiration, both within health workforce and within Canada in another sector. So Kate is going to set us up for the Australian example, and Sarah will walk us through the BuildForce example, BuildForce Canada example, and we've provided you with a little bit of background materials about that. So these are international and national exemplars in terms of which direction we want to go. So coming back to a health system has both a side around population health and a health workforce side. So in the same way that a public health agency was developed after the SARS pandemic, and that was created by bringing together disparate organizations into one sort of coordinated agency. So again, there are some activities already being done. Let's gather those together. And so on the health workforce side, we are proposing a Health Workforce Canada, which could be an agency, could be an observatory, but that this is something that would have some balance and, part of the legacy for this pandemic. Who could or should be involved, again, reflecting that complex adaptive system and the career path of workers would be educators, regulatory authorities, unions and professional associations, employers, data custodians at CHWN and StatsCan, health workforce scientists, as well as the federal, provincial, and territorial governments to really support a coordinated initiative. And there is a role for the federal government here that respects jurisdiction. So the federal government can create a coordinating body that sets data to provinces, territories, and regions, and employers and other data users. The build force example gives us that case. But even the establishment of the Canadian Institute of Health Information is an example of a federal government coordinating body. So provincial and territorial governments can adopt or expand upon a better coordinated and aligned pan-Canadian health workforce information system. And especially for smaller jurisdictions that don't have the resources to develop them themselves. So some of the larger jurisdictions may say, well, we don't need that, but we do need a coordinated approach. And this really is important, not just for planning purposes, but to ensure public safety, in terms of who's practicing where. And then regional planners can utilize these accessible tools. Again, they don't have the capacity to develop them in all of these different regions for better localized planning. So this is our roadmap for our coalition to call for a coordinating agency for better data on all health workers across the career course to increase timely access, really important, that we're not dealing with data that are 1 and 2 and 3 years old, and that people have access to that across a range of data users, and particularly in a way that's accessible. So more decision-making tools for better planning, staffing, retention, and quality of work to address the retention issues. And so our coalition is what we're hoping to sort of move forward in that regard. Our progress to date is that we have over 50 organizations that have signed, over 200 individuals, and we've had more since yesterday, which is great. So we really want to broaden this coalition and have everybody understand that this is part of their advocacy initiatives. Yesterday and today, we're co-developing an action and communication plan, and we want to refine that based on feedback from this community. So it was really, really stressed to us yesterday that the time is now. The time is really, really important. It may have been 10 years ago when the Parliamentary Standing Committee suggested this in 2010, but the next best time is now. So the pandemic and the impending election may be just the impetus to get us to move forward. So, and again, this is one of the key legacies in support of all health workers. We need to do more than just clap in their support.